Hello and welcome back. In this episode, we discuss acid-base disorders. You may have a patient with toxic ingestion, and you need to know what's the next step in the workup in terms of osmolar gap measurement. You may have a patient with non-anion-gap metabolic acidosis, and you are required to analyze urine pH, serum potassium, and urinary anion gap to differentiate renal tubular acidosis 1, 2, 4 from diarrhea. We discussed cases of metabolic alkalosis in which we need to decide if the patient is saline responsive or saline non-responsive. We encounter cases where we need to figure out if the patient has indication for bicarbonate treatment versus urine alkalinization. We discussed the clinical points and lab data to differentiate between hyperaldosteronism from SAME, syndrome of apparent mineralocorticoid excess, including Liddle syndrome, and how to differentiate them from Gittelman and Barter. We also discussed how to clinically make sense of the formulas of urine versus serum anion gap, as well as urine versus serum osmolar gap for both differential diagnosis and management of cases. And finally, we try to make sense of the process of compensations in acid-base disorders to answer questions such as if we are dealing with a mixed acid-base disorder or if a patient with salicylate poisoning with normal looking pH may deteriorate any moment because of an undiagnosed or overlooked mixed acid-base disorder. So as you can see, acid-base disorders is not just, if the pH is less than 7.35 and bicarb is low, that is metabolic acidosis, and if pH is greater than 7.45 and bicarb is greater than 28, then it's metabolic alkalosis. Otherwise, we are dealing with respiratory disorder, right? Oh, by the way, there is this mnemonic mud piles, and please memorize the winter formula and you have mastered acid-base disorders. The bad news is, unfortunately, no. There is much more to acid-base disorders in real clinical scenarios. But the good news is I have tried my best to simplify all of these points in terms of just clinically relevant and high-yield questions and cases. So if you are hopefully scared and excited enough about these scenarios that I mentioned, let's start from the basics. I expect us to be clear about the basic approach about acidemia and the changes of bicarbonate and PaCO2, as I just briefly mentioned. A couple points I want to add to this general approach is, one, please analyze the entire clinical picture, not just the pH numbers. Why is it so? It's possible that the patient has normal pH but have severe mixed acid-base disorder. And the second point is always calculate serum anion gap in any acid-base question you have. It will just take 5 seconds of your time. Why this is important? Because increased anion gap is one of the conditions in which the patient could have acid-base disorder despite normal pH. For example, you could have a patient with salicylate poisoning who has normal pH. Second question, you have a patient with high risk clinical history for an acid-base disorder. You know that normal pH does not rule out acid-base disorder. What are the hints in favor of mixed acid-base disorder? One is presence of clinical hints. In this case, you have salicylate poisoning. We could have antifreeze or windshield fluid ingestion, or a DKA patient, or you could have a patient with multiple myeloma. So you need to have a systemic approach. What are the ABG hints in favor of possibility of a mixed acid-base disorder? Please remember these 4 points. So one indication of mixed acid-base disorder is presence of severe acidemia or alkalemia. What is the pH range? Even though severe acidosis could be analyzed based on patients' clinical response to acidosis, including cardiovascular suppression, we usually consider a pH less than 7.1 as an indication of bicarbonate therapy and that of severe acidemia, while a pH of less than 6.85 is generally considered incompatible with life. On the other side, a pH of greater than 7.65 is considered severe alkalemia. Okay, what's the other hint of mixed acid-base disorder? When CO2 and bicarb have moved in opposite directions. Remember, based on the rules of physiologic compensations, we expect in acid-base disorders for CO2 and bicarb to move in the same direction. Otherwise, we are dealing with a mixed acid-base disorder. The third hint, that's a patient with normal pH but abnormal CO2, bicarbonate, or increased anion gap. And finally, when the measured value for bicarbonate and PaCO2 does not fit the calculated values for compensations. Remember, we never have overcompensation. If the patient is not compensated, it means there is a mixed disorder present. Now, compare and contrast ABG versus VBG. Most variables of acid base are the same except for oxygen content, which logically is considerably lower in the venous blood. However, if venous oxygen content in VBG approximates the ABG value, what is the possibility? That is possibility of cyanide poisoning. Now, one of the essential formulas is the formula of anion gap. So, anions are the negative ions and cations are positive ions. And therefore, what's the concept of anion gap? The concept of anion gap is the unmeasured anions minus unmeasured cations. And if the number is higher, it means we have higher unmeasured anions. However, whenever you look at the formulas, you see we have some cations minus some anions. For example, as you can see here in our first acid-base formula, serum anion gap is sodium minus bicarb and chloride. So we are literally calculating cations minus anions. So why is it so? Because the value of the measured cations minus measured anions give us exactly the same value of unmeasured anions minus unmeasured cations. It actually says anion gap is measured cations minus measured anions. Why is it so? Because if we subtract measured cations from measured anions, it's actually giving us the value of unmeasured anions minus unmeasured cations. And that is what we are using these two surrogates for. So increased anion gap from the normal range of 10 to 15 means we have increased level of unmeasured anions. And unmeasured anions are a surrogate of fixed acids in blood. So increased anion gap simply means we have addition of fixed acids. Remember, we will discuss urinary anion gap later on, and that's again measured by cations minus the major urinary anion, which is chloride. That's sodium plus potassium minus chloride. Also gives us the estimate for unmeasured anions minus unmeasured cations in the urine. So talking about acidemia, what are the two types? One is either respiratory or metabolic. Now, how do we differentiate them? If we have low bicarbonate, we have metabolic acidosis. If we have high PaCO2, that's CO2 greater than 45 millimeter mercury, that is respiratory acidosis. In respiratory acidosis, we have high bicarbonate compensation. In metabolic acidosis, we have a reduced PaCO2 as the compensation. What is the difference in pathophysiology of high anion gap metabolic acidosis versus normal or no anion gap metabolic acidosis? In high anion gap metabolic acidosis, the underlying pathophysiology, as I just alluded to, is addition of fixed acid. In non-anion gap or normal anion gap metabolic acidosis, the pathophysiology is loss of bicarbonate or impaired reabsorption of bicarbonate. Case, you have a patient with metabolic acidosis as evidenced by pH less than 7.35 and bicarbonate less than 22. What is the next step? The next step is measurement of anion gap. If anion gap is increased more than the reference range that you are provided, which is usually between 10 to 15, we have high anion gap metabolic acidosis. If anion gap is not increasing in a patient with metabolic acidosis, you are dealing with non-anion gap metabolic acidosis. Continuing our case, we have high anion gap metabolic acidosis. What is the next step? The next step is determined based on the clinical underlying picture of the patient. And the underlying etiology is guided by our knowledge of differential diagnosis. What is the acronym for differential diagnosis of high-anion-gap metabolic acidosis? That's MADPILE. Methanol, uremia, DKA, propylene glycol or paraldehyde or fenformin, iron or isonazid, all differential diagnosis of lactic acidosis, ethylene glycol poisoning, and finally salicylate poisoning. So based on this, if you have a patient with hyperglycemia and high-anion-gap acidosis, your very first next test will be assessment of blood glucose and ketone bodies to rule out DKA. However, if you have patient with sinus symptoms compatible with intestinal ischemia or strangulated hernia, etc., your next best test would be ordering lactate to see if the patient has lactic acidosis. Now, our case is a case of toxic ingestion. What is the next step in the assessment of this case of high-anion-gap metabolic acidosis? In the case of toxic ingestions, next step is assessment of serum osmolar gap. What's the relevance of serum osmolar gap? If serum osmolar gap, and I repeat, serum, not urine, but serum osmolar gap is greater than 10, it confirms presence of ingestions such as methanol, ethylene glycol, propylene glycol. However, in a patient with ingestion of an unknown substance, the serum osmolar gap is normal. That's value less than 10. What's the diagnosis? Please remember that's specific for salicylate poisoning. Likewise, if you have a case of a patient with metabolic acidosis with anion gap being within the normal range, what is the next step? We need to measure urine NH4+, either directly or indirectly by evaluating urinary anion gap or urinary osmolar gap. Why we need to have a proper understanding of NH4+ excretion in the urine in non-anion-gap metabolic acidosis? Please remember, non-anion-gap metabolic acidosis is either due to impaired aldosterone distal nephron axis, in which distal nephron fails to reabsorb newly synthesized bicarbonate, secondary to impaired hATPase function in alpha intercalated cells of distal nephron. In this condition, H+ secretion is impaired either due to renal tubular acidosis type 1, the distal type, or due to impaired function of aldosterone in stimulating distal nephron hATPase, and that is RTA type 4. Now, because there is not H+ secretion in the urine, the urinary buffer system, which is NH4+, is not working, and the value of NH4+ in the urine is reduced. That is why we say in impaired aldosterone distal tubule axis, we have low urinary NH4+. Remember, NH4+ itself functions as a surrogate of both H+ and chloride, because chloride is also excreted in the tubule as NH4Cl. Now, how analysis of urine anion gap help us identify this condition? If the value of urine anion gap, that is sodium plus potassium minus chloride, is a positive value, it simply means unmeasured anions minus unmeasured cations are a positive value, and it means there is not much unmeasured cation in the urine, and it means there is not much NH4+ in the urine. And put it simple, positive urinary anion gap means impaired aldosterone distal tubule function or impaired secretion of hydrogen and formation of NH4+ urinary buffer. In what conditions this happen? In type 1 or distal RTA, as well as type 4, also known as hyperchloremic RTA. Both are the same. In both conditions, H+ secretion is impaired. In RTA type 1, the pathophysiology directly involves hATPase, while in RTA type 4 or aldosterone deficiency, it's the function of aldosterone on hATPase that is impaired. Net result is impaired secretion of protein into the nephron. What if the urinary anion gap value is negative? It means unmeasured anions minus unmeasured cation is negative. It's the same as saying measured cations minus measured anion is negative. And it is as if saying that there is a lot of unmeasured cations in the urine. In other words, we have enough of NH4 plus in the urine. Or you can just simply look at this chloride, and every time you see this chloride, think you are looking at NH4 plus. And because we have enough NH4 plus in the urine, the urinary buffering system is working. That means the aldosterone distal nephron system is working. So the basis of non-anion-gap metabolic acidosis is not in distal nephron, and it is not dealing with aldosterone deficiency. So the conditions that are left are either some defects in proximal nephrons, such as RTA type 2, in which proximal tubule reabsorption of filtered bicarbonate is impaired, such as in Fanconi syndrome, or we are dealing with just extrarenal causes of non-anion-gap metabolic acidosis. So if you have a case with non-anion-gap metabolic acidosis and you knew that you need to measure urinary anion gap and the value is negative, what are the differential diagnoses? The differential diagnoses are renal tubular acidosis type 2 versus GI causes. The top of the GI causes is diarrhea, followed by pancreatic fistula. Remember, diarrhea and pancreatic fistula simply means loss of bicarbonate, right? And in general, please remember, lower GI fluid loss is associated with acidosis because it's associated with bicarbonate loss, while upper GI fluid loss, that is proximal to ligament of traces, such as vomiting, is associated with loss of hydrochloric acid and therefore metabolic alkalosis. Now, question. Analyze the chloride level in diarrhea versus vomiting. Well, analysis of chloride level in vomiting is easy because the patient is losing hydrochloric acid, so it is a hypochloremic metabolic alkalosis associated with vomiting. How about the chloride level in diarrhea? Chloride level in diarrhea is usually increased, and understanding of this requires our understanding of the anion exchanger in GI system that's distributed all over the lower GI system and pancreatic ducts. The function of anion exchanger, that is bicarbonate chloride exchanger in GI tract, is different from the function of distal nephron anion exchanger. In distal gastrointestinal tube, anion exchanger secretes bicarbonate into the lumen and reabsorbs chloride. In distal tubule, the HATPase coupled, I repeat, the HATPase coupled anion exchanger reabsorbs newly synthesized bicarbonate for secretion of chloride. This last two sentences will help you answer any electrolyte abnormalities in RTA 1, 2, 4 diarrhea and pancreatic fistula and nasojejunal tube dealing with chloride, pH, and potassium. Please repeat those couple sentences till you completely master the idea. So in diarrhea, bicarbonate is lost because that side of equation has lost the product. The entire system moves to replace what is lost, so we will have further production of bicarbonate into the lumen for reabsorption of chloride. This is what happens in diarrhea because the GI anion exchanger secretes bicarbonate and reabsorbs chloride. And in diarrhea, it will be hyperfunctioning, and that's why in diarrhea we will have hyperchloremia. And as you know, almost all the references refer to as hyperchloremic metabolic acidosis as a term equivalent to non-anion-gap metabolic acidosis and renal tubular acidosis. Now, what about the distal nephron's anion exchanger? It is the inverse of the GI anion exchanger. Please remember this, that in distal nephron, the anion exchanger, one, reabsorbs newly synthesized bicarbonate, as opposed to reabsorption of just filtered bicarbonate happens in the proximal tubule in a sodium coupled mechanism. And second, the function of distal nephron anion exchanger is dependent and contingent on the function of HATPase. So if HATPase is not working as seen in renal tubular acidosis type 1 and 4, the anion exchanger also would not work. And therefore, we will not have reabsorption of new bicarbonate, and therefore we will have non-anion-gap acidosis. But also because it's not working, the secretion of chloride is also impaired, so we will have chloride retention, also known as hyperchloremia. And this little anion exchanger of distal nephron is why non-anion-gap metabolic acidosis is also referred to as hyperchloremic metabolic acidosis. Why we do not have hyperchloremia in high-anion-gap metabolic acidosis? Because in high-anion-gap metabolic acidosis, the anion exchanger works. Actually, that is kidney's response to acidosis. And because it works, we have increased reabsorption of bicarbonate secondary to increased secretion of hydrogen. And because of increased function of the distal nephron anion exchanger, we will have increased loss of chloride for reabsorption of bicarbonate. And therefore, we would not have hyperchloremia in high anion-gap metabolic acidosis. Next question, why patients under nasojejunal tube will have acidosis and what is the type of their acidosis. Again, nasojejunal tube suctions the fluid from the jejunum, and that means loss of bicarbonate, similar to what happens in diarrhea. Therefore, these patients will have hyperchloremic non-anion-gap metabolic acidosis because the basis of their acidosis is loss of bicarbonate, not synthesis of new fixed acid. Remember what were the examples of newly fixed acid addition to serum? Mud piles. High anion-gap metabolic acidosis is addition of new acid. Normal anion-gap metabolic acidosis means hyperchloremia and loss of bicarbonate or impaired bicarbonate reabsorption. Talking about impaired bicarbonate reabsorption, what type of RTA is associated with impaired proximal tubular reabsorption of bicarbonate? That's RTA type 2. Now, what is the value of urinary bicarbonate? You have a patient with diarrhea and metabolic acidosis. You calculate the anion gap and it is within the normal range. You are asked what is the way to figure out if renal response to acid-base abnormality is appropriate. Given the fact that in diarrhea we are not dealing with renal tubular acidosis, we expect normal renal response to acidosis. However, the way to measure if we have proper kidney response to non-anion-gap acidosis is again to see if the main renal buffering system is functional, and so that's either by measurement of NH4 plus in the urine or its surrogates, which is urinary anion gap. Now you look at the answers provided and you do not see either NH4 plus or urinary anion gap, but you see urinary osmolar gap. How do we analyze the urinary osmolar gap? Well, just remember that under normal conditions, that is when the patient does not have acidosis, urinary osmolar gap is less than 150. Also, if the patient does have acidosis, but kidney function is impaired in terms of response to acidosis, it fails to increase NH4 plus in the nephron, and therefore urine osmolar gap remains low and less than 150, similar to normal conditions. However, if kidney is functioning properly, the proper response of kidney to metabolic acidosis is increasing urinary osmolar gap to values more than 400. Why is it so? Because increased urinary osmolar gap simply means that we have increased secretion of NH4 chloride, ammonium chloride into the urine as a response to acidosis. Remember, the NH4 plus system is the major renal response to acidosis. And presence of a lot of NH4 in the urine means H plus secretion is functional, means aldosterone distal tubule axis is working, means chloride is secreted together with NH4 plus. And secretion of both NH4 plus and chloride is raised the value of urine osmolar gap. Put it simple, increased urine osmolar gap in the setting of diarrhea or any type of GI conditions indicates proper renal response to non-anion-gap acidosis. By the way, do you remember what's the formula for osmolar gap? Well, osmolar gap has just one simple or single formula for both serum osmolar gap and urinary osmolar gap, and that is measured osmolarity versus calculated osmolarity. Now, what is the formula for calculated osmolarity? For both serum and urine, the calculated osmolarity is 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8. So serum osmolar gap is measured serum osmolarity minus this calculated osmolarity, and urinary osmolar gap is measured urine osmolarity minus calculated osmolarity. By the way, do you remember where we measure serum osmolar gap? We measure serum osmolar gap in high-anion-gap metabolic acidosis to differentiate ingestions of different substances with increased serum osmolar gap to values more than 10 compared to salicylate, in which the serum osmolar gap would be the normal value of less than 10. When do we measure urine osmolar gap? We measure it as a surrogate of ammonium, similar to the way we measure urinary anion gap, or directly measuring ammonium itself to see if we are dealing with conditions impairing aldosterone distal nephron, or we are dealing with conditions with proper renal buffering response to acidosis. Simplify the differential diagnosis of non-anion-gap metabolic acidosis. We either have positive urine anion gap, or low urinary NH4, or decreased urinary osmolar gap to values less than 150. That indicates impaired aldosterone distal tubule axis, and it is seen in RTA1. Logically, that's the distal nephron, or RTA4. Logically, that also deals with distal nephron through aldosterone deficiency. On the other side, if our non-anion-gap metabolic acidosis is associated with negative urine anion gap, or a urine osmolar gap that's said increased or the value is more than 400, or we have measured the NH4 plus and we have high to normal urinary value of this buffer, we are dealing with either proximal or type 2 renal tubular acidosis, or GI causes such as diarrhea on top of the list, followed by pancreatic fistula, nasojejunal tube, or chronic laxative abuse. Case: if you have a patient who received sodium chloride for any cause of IV fluid resuscitation, and now the patient seemed to have pH of 7.27. You are asked why the patient has acidosis. Remember, addition of chloride-rich substances, either as IV fluid or as ingestion of acidic substances with chloride base, would result in hyperchloremic non-anion-gap metabolic acidosis. And as long as the kidney function is normal, we will have negative urinary anion gap. Now the answer is why it happens. Remember, if you have received a lot of chloride through IV fluid, chloride and bicarbonate can compete across the cellular membrane the same way that potassium and hydrogen compete to enter or exit the cells. So if you have a lot of chloride in the extracellular fluid, for the maintenance of electroneutrality, bicarbonate would be shifted into the intracellular compartment. Now, pay attention to the fact that their direction is opposite the direction of potassium and hydrogen. But anyway, the net result would be a lot of bicarbonate shift from the intravascular compartment into the intracellular compartment with resultant acidosis due to loss of bicarbonate. Same happens if the patient has consumed a lot of acidic substances with chloride base. In the GI tract, remember we had that anion exchanger whose function is to secrete bicarbonate and reabsorb chloride. Now, if you have a lot of chloride inside the lumen, it is similar to having lost a lot of bicarbonate, and therefore the exchanger starts working to secrete more bicarbonate into the lumen, and the net result would be also hyperchloremic, non-anion-gap metabolic acidosis. Now, we already discussed renal tubular acidosis, but their differential diagnosis deserves some extra attention. So what's the very first question for differentiating different subtypes of RTAs? The very first question, in my opinion, is to see if you are dealing with hyperkalemia or not, because type 4 is the only type that is hyperkalemic. So the challenge is to differentiate type 1 and 2 because both these types are hypokalemic. What's the best way to differentiate these two types? I want to draw your attention to the fact that urine pH is not the best way to differentiate them, even though most of the review resources say, oh, if it is type 1 or distal, you will have increased urine pH to values more than 5.5, and that's because H+ is not secreted into the lumen. Well, first of all, the same thing happens also in aldosterone deficiency and RTA type 4, and the second thing is in RTA type 2, which is the impaired proximal tubular reabsorption of bicarbonate. Initially, we could have bicarbonate loss in the urine and therefore high urinary pH. It is only in the late course of prolonged renal tubular acidosis type 2 that the entire body's resources of bicarbonate are depleted, and therefore we start having less and less bicarbonate filtered, and therefore less and less being in the urine, resulting in reduced urinary pH. Furthermore, if renal tubular acidosis type 2 is caused by an acute process, especially if that's due to acetazolamide, urine pH will be high, similar to renal tubular acidosis type 1. I'm just trying to tell you, don't trust the urine pH as a means to differentiate RTA 1 and 2, the hypokalemic types. In my humble opinion, contrary to several resources, hyperchloremia could be a reliable means to differentiate them, but I don't want to discuss why I think so. Simply remember that in RTA type 2, the anion exchanger function is not impaired, therefore we do not have chloride retention necessarily. That said, the most reliable means to differentiate RTA 1 and 2 is 1, clinical, that is knowing the underlying etiology, and 2, paying attention to the factors we discussed in terms of urinary ammonium and its surrogates, that is urine anion gap and urine osmolar gap. Now, beginning with these lab findings, why is it so? Because in RTA type 2, which is the proximal type, the aldosterone distal nephron axis is functional. So we have proper NH4 plus response to acidosis. We have negative urinary anion gap. We have increased urine osmolar gap to values more than 400. Again, in proximal type 2 renal tubular acidosis. On the other side, in type 1 or distal type, that is impaired function of HATPase. Therefore, NH4 plus buffering system is not working, therefore urinary anion gap is positive. In other words, urine osmolar gap is less than 150 or reduced. Now, what are the underlying causes as a means to differentiate them? That could come very handy. Well, for type 1 or distal RTA, we are dealing with a bunch of drugs such as amphotericin B, ifosfamide, analgesic-induced nephropathy, some important autoimmune conditions. Please remember sarcoidosis and Sjogren in association with type 1 RTA, as well as some genetic abnormalities, including obstructive anomalies of urinary tract and hypercalciuria. Put it simple, genetic, autoimmune, and medications as the underlying etiology. Now, if you ask what are the underlying etiologies of type 2 or proximal RTA, you should remember any condition that can impair proximal sodium-dependent reabsorptive processes such as amyloid deposition in the kidney tubule, multiple myeloma, and all the underlying causes of Fanconi syndrome. Don't confuse Fanconi syndrome with Fanconi anemia, please. Causes of Fanconi syndrome include Wilson disease, tyrosinemia, glycogen storage disease, cystinosis, multiple myeloma, as I mentioned, and a lot of drugs that can cause impaired proximal tubular reabsorptive function. Now, we mentioned ampho-B and ifosfamide associated with RTA type 1. What medications are associated with RTA type 2? Again, we have ifosfamide, but we also have the typical renal toxic drugs such as aminoglycosides. Then we have tenofovir, cisplatin, tenofovir, expired tetracycline, and finally, don't forget lead poisoning as a cause of Fanconi syndrome. Now, among the medications associated with type 2 RTA, never forget the most important one, and that is acetazolamide, that selectively impairs bicarbonate reabsorption in proximal tubule, not associated with Fanconi syndrome. That's the only target function of acetazolamide, impaired carbonic anhydrase in proximal tubule. Now, if you have a patient who takes ACE inhibitors and ARBs, or ARBs, angiotensin receptor blockers, these two should never be used together, and you found the ABG report showing non-anion-gap metabolic acidosis, what type of acidosis you are thinking of? Well, ACE inhibitors or ARBs impair aldosterone function, and therefore we are dealing with type 4 RTA. Again, I'm just trying to draw your attention to the underlying etiology as a means to differentiate them, though type 4, as I said, is easy to differentiate because it is the only hyperchloremic type. Now, what complications you expect to see as a means to differentiate type 1 from type 2? Well, we mentioned type 1 necessarily has increased urine pH, while type 2 in later course will have low urine pH. Therefore, type 1 is associated with the kidney stones that deposit on high urine pH. In other words, calcium phosphate kidney stone is possible in type 1. What about the possible complication in type 2? Well, remember, Fanconi syndrome is manifesting or diagnosed by seeing any of the normally reabsorbed substances of proximal tubule in the urine, including amino acids, glucose, bicarbonate, but also phosphate. These are mainly reabsorbed in proximal tubule. So we will have hypophosphatemic rickets and or osteomalacia in patients with type 2 or proximal RTA. Now, regarding the management of RTAs, the treatment is what usually we need to address the underlying etiology and risk. If you ask in what RTA amiloride or triamterene is contraindicated, the answer is type 4. These are examples of potassium sparing diuretics. The patient already has high potassium. We don't want to use these diuretics on the patient. Heparin injection or diabetes are risk factor for what type of RTA? Type 4 RTA. Now, at the end, let's review some management scenarios in patients with metabolic acidosis. When dialysis is indicated, from the mnemonic AEIOU, acidosis, electrolyte abnormalities, fluid overdose, uremia are all indications of dialysis if certain conditions are met. In the case of acidosis, acidosis needs to be severe, that is pH less than 7.1, and fail to respond to initial medical management. You remember we also mentioned that severe acidosis in which pH is less than 7.1 is an indication of bicarbonate therapy. So definitely that's what we first try. Now we have a couple ingestions. I want you to always remember antifreeze is a source of a lot of substances associated with high-anion-gap metabolic acidosis. So the question is not challenging in terms of the management. Management would be preferably fomepizole. But how to figure out which one of those substances is responsible for the clinical scenario. So first of all, what are the substances in antifreeze we need to keep an eye on? First is ethylene glycol, then we have methanol and propylene glycol. Next, we have a case of a patient who has consumed some homemade spirits in a party and now complains of some visual abnormalities. When you visit the patient in ER, he mentions that he sees flickering white spots resembling snowstorm in his visual field. True or false, urine analysis will show envelope-shaped crystals in this patient. That's false. The patient has all the features associated with methanol poisoning, including homemade or moonshine spirit consumption and this snowstorm pattern of visual loss. Even if the patient had consumed ethylene glycol containing fluids such as antifreeze, with this symptom we would be more concerned with the methanol poisoning. Next question about this person is true or false. Best step in the management is ethanol. That's false. Fomepizole is the best treatment, not only for ethylene glycol but also for methanol poisoning. Now, if fomepizole is not available, true or false treatment is consumption of ethanol. That's false. It is IV infusion of 10% ethanol. Now, what are the other possible routes of methanol poisoning? In addition to antifreeze and specifically moonshine homemade spirits, always remember windshield fluid. Next case is a patient with history of alcohol use disorder, known to ER personnel for his several visits, but this time he has severe agitation and hallucinations, and therefore he receives IV diazepam. In the next morning follow-up, his agitation and tremor are improved. However, the ABG shows a pH of 7.22, sodium of 135, chloride of 100, and bicarb of 12. What is the next step in the management? The numbers show high-anion-gap because sodium 135 minus chloride of 100 plus 12 gives a number 23 for anion gap. So next step will be measurement of osmolar gap of the serum. Now, if osmolar gap is more than 10, what is the underlying etiology in this patient for high anion-gap acidosis? Well, osmolar gap greater than 10 indicates intake of some fixed acid. Now, based on the history and supervision that the patient received in ER, the most likely culprit is propylene glycol. Why is it so? Because perhaps one of the most common routes of propylene glycol poisoning is through IV or oral medications that contain propylene glycol as a solvent. The most common of these medications are benzodiazepines. Next, you have a patient with altered mental status whose friend in the ER mentions that he has been eating and drinking excessively in the previous days. What is the management if ABG shows a pH of 7.19? This is most likely the first manifestation of diabetes in the form of DKA. We need to calculate patient's anion gap and order blood glucose. If DKA is approved, we initiate with insulin, IVF, and potassium management. Following our MUDPILE acronym, what is the management for iron ingestion or poisoning? Gastric lavage and halobut isoniazid, we give activated charcoal. Next is a patient with diabetes in his history, controlled by oral antidiabetics, who comes to ER with altered mental status. ABG shows metabolic acidosis, but assessment of serum ketones is negative and the blood sugar is within the normal range. What is the most likely culprit for his abnormality? Always remember, metformin is among the medications with side effect of lactic acidosis. What other medications could be associated with lactic acidosis? One group are salicylate and other electron transport chain poisons such as cyanide. The other group are the drugs causing mitochondrial dysfunctions such as nucleoside reverse transcriptase inhibitors. Also remember the mechanism of high anion-gap acidosis with ethanol, methanol, and ethylene glycol is lactic acidosis. What other conditions fall among the differential diagnosis of underlying etiologies for lactic acidosis? Top of the list is tissue hypoxia, including ischemic bowel, shock, heart failure, respiratory arrest, Then we have conditions associated with enhanced metabolic rate, including seizure and exercise. Then we have conditions associated with impaired removal of the lactate, and those are renal and kidney failure. Very important question, and especially in relation to the diabetic case that we talked about. What is required for us to diagnose a patient with metabolic acidosis of high anion gap to be due to lactate? Serum ketones should be absent. Why is it so? Because conditions other than diabetes could also be associated with ketoacidosis, including alcoholism itself. It could also be associated with lactic acidosis or starvation. Finally, you have a recent immigrant whose PPD was positive and has been started on some TB regimens. Their recent blood tests show mild acidosis. What is the mechanism of acidosis? It is lactic acidosis as a side effect of isoniazid. For what conditions associated with metabolic acidosis, activated charcoal could be used? Commonly for either isoniazid or salicylate poisoning. More on salicylate poisoning in the next episode of acid-base disorders. Finally, what's the recommended management for the non-anion-gap metabolic acidosis? Addressing the underlying etiology. So, regarding acidosis, first figure out if it is metabolic or respiratory or mixed, based on the criteria of mixed acid-base disorder we mentioned. If it's respiratory acidosis, you are mainly dealing with a condition associated with impaired ventilation, with resultant CO2 retention. We discussed the management for these conditions in the episode dedicated for hypercapnic respiratory failure and its management. However, if you are dealing with metabolic acidosis, the first test is measurement of anion gap. If anion gap is increased, the next test is determined by patient's underlying etiology and clinical history and physical. However, if there is any ingestions involved, the next test is serum osmolar gap. The value more than 10 indicates ingestion of methanol, ethylene glycol, propylene glycol, but the value less than 10 in patients with metabolic acidosis and ingestion indicates salicylate poisoning. Now, if anion gap is within the normal range of 10 to 15, we are dealing with normal anion gap, hyperchloremic metabolic acidosis. The next test is to evaluate urine ammonium or its surrogates that are urine anion gap or urine osmolar gap. If urine anion gap is negative or urine osmolar gap is more than 400 or we have enough ammonium in the urine, that indicates the normally functioning aldosterone distal tubule axis produces enough NH4 plus buffer. So we are dealing with either RTA type 2 or GI loss of bicarbonate. However, if urine anion gap is positive or urine osmolar gap is less than 150 or the ammonium in the urine is reduced or absent, we are dealing with conditions with impaired aldosterone distal nephron axis that includes renal tubular acidosis 1 if hypokalemic or 4 if hyperkalemic. Stay tuned for the next episode focusing on metabolic alkalosis, compensation formulas, and uses of urine alkalinization or acidification and salicylate poisoning.